The beating in your chest is a good thing. Smarter Heart University and Dr. Scott on AM 970, The Apple.
Welcome back and good morning to your Smarter Heart University. Well, phone difficulty number 2, but actually we're glad that Marion called and we're glad we were able to get her in, and we learned a thing or two along the way each time we do this show. Answer to the pop quiz about aspirin, because my friend Dr. Oz has made a statement about taking 81 milligrams of aspirin daily, 162 milligrams daily for all women. Actually, I'm going to break it down a little more scientifically. So what age is a healthy woman? Now, a healthy woman best get protected from taking an aspirin a day, 35 years of age, 45 years of age, or 65 years of age. Actually, it's 65. Aspirin prevents cardiovascular events pretty much in all women over 65, but healthy women between 45 and 65, doctors really haven't found that much benefit for the heart specifically. And there's a slight benefit seen with stroke prevention. The addendum to this, and again, we're going to talk a lot about this next week in our lecture. There's no such thing as borderline diabetes. I'm going to say that a couple times. The addendum in women is a woman with multiple risk factors: high blood sugar, high blood pressure, or overt diabetes. In this case, there's a pretty good indication that a woman might benefit from taking an aspirin. And as always at Smarter Heart University, we're going to say you should discuss this with your doctor to determine your degree of risk. Don't start taking aspirin. So section 3 of this class about women and heart disease is the WISE syndrome. This is this study that came out that turned everything on end. It's called the Women Ischemia Symptom Evaluation. What does that mean in English? Is the symptoms that women get with coronary disease and blockages. So it came out 6 years ago. It was a dramatic change in how the world looked at women and heart disease. It was done by who's still the prominent female cardiologist and who writes and heads the guidelines, Noelle Berry-Merce, every year. She's still the educator for all of us that want to learn everything that has to do with women and heart disease. But it looked at, number one, how women got disease. Number 2, how they presented with symptoms. They furthered what we learned in 1 year earlier, how they got tested, what worked to diagnose their blockages, which is a very important step, and how they got treated. The conclusions turned the medical world on end, as I said. The first major finding was that women can have symptoms like chest pain or all the other things that I discussed, but have no overt blockages on their coronary angiograms, the catheterizations that Dr. Kaiser and I do. Number 1. Number 2, their stress tests can be normal. Number 3, and this is what they found, it was so interesting, they can have abnormal higher tech scans like PET scans and cardiac MRIs and CAT scans, but their usual studies can be normal. Why? Well, what they concluded from this was that a woman's artery itself can be very abnormal in size, and its lining can be completely dysfunctional itself, causing it to constrict. And we know why now. Class, everybody knows why. It's because of the lack of estrogen or waning estrogen, so that blood flow is limited. Well, so how is it missed on angiograms? Well, Thomas Dayspring, who was one of my mentors in lipidology, the cholesterol field, I have to give him props on this. He said angiograms are like donut holes. They miss the substance surrounding it. I love that. I always have to use it. Women end up with a different form of heart disease than men. Their blockages are diffuse throughout the lining of the artery, where a man's is focal and discrete. And I remember you had a case like this where there was, and you were doing a catheterization, and I remember watching your study, and you were fixing a 80% blockage, but yet there was like a long 50 or 60% narrowing, and I just kept honing in on the WISE study, saying, I wonder if we fit the stent in, is she going to continue having chest pain? I don't remember the particular, but what do you think?
Actually, that's there's even more recent data on the WISE study that came out and looked at these. The traditional is that blockages are only significant if they're 70% blocked, the artery is 70% blocked or more. But actually in women, it may be more there's more detail to that, and the more detailed analysis of the Y study just came out and looked at. There's probably something called a flow reserve,
right,
that these 50 to 60% blockages actually in women becomes more important. How does the lining of the vessel impact the flow compared to just how narrow it is? And in women, this probably is becoming more of an important event, because these blockages, these 50 to 60% blockages that have impaired function, are leading to worse outcomes.
Yeah.
And that's what this reanalysis looked at, that women who have this dysfunction,
right,
not just a percent blockage,
right,
do worse.
Well, it's as I tell patients, why could that cause chest pain, even though it's not blocking the blood flow and oxygen? We have two hormones that govern whether how tight your artery gets when you need high pressure or how relaxed it gets when you don't need it. We lose the ability to relax. I talked about this earlier, but it's worth repeating again. We lose that when we start forming blockages. So we get the nasty hormone that keeps things constricted, and we lose the ability to relax the arteries. This is different than this microvascular or the branches, and it probably is a combination of all of that. Where there's smoke, there's fire kind of approach, head to toe approach, where if you have one, you're going to kind of have the other. Now, they looked at symptoms in this study just like they did in the 2003 trial, and they got conclusions that were different. Well, they added to the conclusions. This is what they found. 50% of the women who had no significant blockages but had symptoms, and again, it wasn't just chest pain, folks, if they had the risk, the diabetes, the cholesterol, the smoking, the blood pressure, and they weren't treated, 65% of them developed overt heart disease, stents, bypasses, heart attacks within 5 years. Just 5 years, people. So how do you diagnose it? Well, as I stay tuned for the last section. That's a good tease. But they stuck ultrasound cameras down the arteries. They're called intravascular ultrasound. Used CAT scan angiograms, which is one of obviously Dr. Kaiser's foray, as well as special MRIs with contrast, as well as the stress echo. And we're going to touch on that at the during next segment. They also looked at hormone replacement and concluded the following. So I want to make sure we get this in before the end of this segment. They concluded the following. Number one, the take-home point today is hormone replacement therapy is not useful to prevent coronary disease. It is useful to reduce short-term control of symptoms. Short-term. I have to say it a couple times. It should be delivered, and this is important, only by health care professionals, even if it's bioidentical, okay? The absolute risk of a bad outcome early on in an early postmenopausal female without any known heart disease that it's even already on hormone replacement therapy is low. So I've had a number of women over the past 10 years come in, and when this study came out 6 years ago, it corroborated the hormone replacement trials, which said the same thing. And they said, oh, you know what? I heard about this. I took myself off. And, well, how long were you on it? 8 years. There's nothing to worry about. If you have no disease, you were fine. And basically, the risk of events for a woman at risk, and again, you need to see your doctor to determine that risk. So if you're at risk for vascular disease, you should evaluate that first before attempting to start hormone replacement therapy. And this was their final statement. If at all possible, to reduce symptoms or osteoporosis, you should try other measures. And of course, we blog, and again, Facebook, and our SmarterHeartUniversity.com. We did a whole thing on the calcium supplements and heart disease, and they're going back and forth on this, folks. It was a great question that somebody had asked on our Facebook page, and we urge you to sign up and ask questions away. And we blog every morning about something that comes in. What's your take on their diagnosis about the heart disease symptoms and lack of angiographic findings.
It doesn't surprise me at all. I mean, we see that clinically almost every day. Patients, women who come in with symptoms of chest pain, or the more classic for women, the women's syndrome of chest pain. I tell my women it's a disservice to women to say you have atypical chest pain. You don't. You have very typical symptoms for you, which is very different than men, which is what medicine, and at least in heart disease, has been based on in the tradition of medicine, has been male-based.
Old school?
Women are different. Old school. And we do it differently. We do it very differently.
A lot of people are doing it differently. And there's a lot of people out there that are approaching, the integrative field and the alternative field and the regular cardiology field all together and trying to find better ways to do this than using hormone replacement therapy, as well as really approaching each particular patient. As we say a lot, I use this term, one size doesn't fit all. Certainly, women should be treated more aggressively and with a fine-tooth comb from that standpoint. So on to the next break. Pop quiz number 3. What percentage of high good cholesterol in women, that is greater than 60, is seen with women and heart disease? 20%, 40%, or 60%? In the old days, good cholesterol, women, you were told you'll live forever. So what percentage of high good cholesterol, the number over 60, is still associated with heart disease? We'll be right back with your Smarter Heart University.